Good. Okay, I think I'm recording now. Okay, so I have the chapters here. I did use the same textbook, so I know which textbook you're using. It's like the famous MedSurg textbook. The way I like to go through things is I like to teach you how I think and how I studied. Um, and definitely any sorts of key points, because even though this is MedSurg, you have a very high chance of being asked about any cardiac medications because it relates to these cardiac diseases and disorders. So, for example, on my MedSurg quiz, they asked me a question about what is an adverse effect of giving ACE inhibitors, which are a class of antihypertensive drugs that causes a dry, nagging cough and angioedema. That was the answer, but it relates to a patient being diagnosed with hypertension. It's a part of the drugs that you give to treat those disorders because that's a part of your nursing intervention. So MedSurg is not solely just the diseases and the disorders, it's also medications. That's why I recommend reviewing cardiac meds before, just in case, because you don't know if they may or may not put medications. So, just in case, I recommend looking through your cardiac drugs. But yeah, so the first thing that I want to talk about is coronary arteriosclerosis. I'm very bad at pronouncing things, so I apologize. But the thing about this disease is that it's a buildup of lipids, or it basically causes plaque formation in the arteries. So you're going to get like a buildup, which is going to cause obstruction of blood getting to the heart. And the really important thing about the coronary arteries specifically is that they control the blood flow getting to the heart. They are the arteries that are directly on the heart and they perfuse it. So if there's a blockage of any sort of like plaques or vasoconstriction, anything, that is going to affect the perfusion of the heart and its ability to pump blood to the rest of the body. So that's why it's so important to know about coronary arteriosclerosis, because it is the foundation of all of the different type of cardiac disorders, as you'll see. As a I guess you can call it predisposing factor, is coronary arteriosclerosis. So knowing about this disorder is really important. It can lead to pretty much everything, going from hypertension to heart failure to who knows what. So it's really, really important to know that. Okay, so basically with this, manifestations include anything that causes ischemia to the heart. So ischemia means that you're having lack of perfusion, right? If you're having plaque buildup, you're having something blocking those arteries, you're going to have something causing lack of perfusion to the heart. So chest pain or angina pectoris is caused by ischemia or lack of perfusion. So, a common side effect that you get is chest pain. Another thing that you can get, which is not a common symptom, right? Because chest pain and pain that radiates from the jaw down to the left arm are very common signs of a myocardial infarction, which is something, as I said, coronary arteriosclerosis can cause. So it can lead to pretty much anything. But some of those common manifestations are chest pain and pain that radiates from the jaw to the left arm. But in women and elderly, sometimes they have like not the characteristic symptoms. So you may experience something if you were a woman or of the elderly, epigastric distress, such as like nausea and vomiting, or stomach pain, which would be really different than the normal characteristics. So it's important to know that that is one of the possible manifestations. Heart failure, because as I said, this disease is almost like the foundation for all the other ones. So it can cause heart failure, which is the heart's failed ability to pump blood to the rest of the vital organs. So that becomes an issue. Also, we have sudden cardiac death, right? If you're not getting blood to the heart, you might have cardiac arrest, the heart stops. So these are all things that relate to pathophysiology. That's why pathophysiology is so important, because if you understand how these diseases work, you understand the manifestations, which allows you to better understand all of the symptoms, especially because it can be a lot. But you're going to see also the risk factors, things that can be caused by all these other disorders are very similar. Like I said, coronary arteriosclerosis is the foundation for a lot of them. So these manifestations that you're going to see are going to repeat, like chest pain, because these are all cardiac disorders that are caused by similar things. So, as I said, right, we're talking about something that blocks perfusion to the heart. So, risk factors include hyperlipidemia or high cholesterol levels, because that can induce or cause that cholesterol buildup. Tobacco use, because it can also cause plaque buildup. Hypertension, because as the vessels continue to constrict, they're going to constrict so much to the point where they're not really going to be able to do what they need to do. The heart's not going to be able to pump. So if you are going to have vasoconstriction of some sort, you're going to have potential lack of perfusion, and that's some of the manifestations of coronary arteriosclerosis. Metabolic syndrome, you're going to see this come up a lot, so I would really know them. It might not be on your med-surg exam, but it will come up in the future. So metabolic syndrome is a bunch of different things. It's a bunch of different abnormalities that affect metabolism. So basically, this includes enlarged waist circumference, elevated triglycerides, or another way of saying fat levels, reduced HDL, which is that good cholesterol that we need, hypertension, and elevated glucose levels or sugar levels. So we really want to watch out for that. But these are all things that are modifiable, right? You can watch your blood pressure by reducing your sodium intake. You can prevent diabetes, right, by monitoring your sugar levels and having an active diet. You can reduce your cholesterol levels by not consuming as many dairy products and products that contain cholesterol. So it's really important, and probably one of your questions will be about how do I teach a patient how to manage their symptoms or reduce risk factors for having cardiovascular disease. And we want to tell them, hey, we want you to watch your diet. Don't eat too much salt. Be careful with your cholesterol, like things like that, because all of these are modifiable or they can be changed. They can be changed, or lifestyle habits can change, which can aid in helping your patients reduce the possibility of obtaining any sort of cardiovascular disease, obesity, physical inactivity, all of these things. But the major point is teaching. That's a part of our role, the teaching part. So there could be a question like that. So when you're thinking about coronary arteriosclerosis, remember, it's a vasoconstrictive or an obstructive form of cardiovascular disease, because the plaque buildup, right, makes the vessels work harder to try to get blood to the heart. And the coronary arteries, as I said, are so important to getting perfusion to the heart. And now we're going to start having manifestations that relate to that loss of perfusion. So that's why we have the chest pain, the pain that radiates from the jaw to the left arm, and things like that. So prevention, everything that I said about preventing CAD is something that it could be a question, right? Controlling the cholesterol levels, watching your dietary, and you're making sure you're eating good fruits and vegetables and things like that, making sure they're having physical activity. Another thing is medications. As I said before, medications can be brought up on your med surg. It's a fair game because they know what you're learning about. They know you're supposed to either have learned cardiac drugs or are learning cardiac drugs, which means they're fair game for your exam. As I'll mention, if you didn't put your SFCID number into the chat, please do that. But an important medication that you might give, right? One of the things that we said can cause that plaque buildup is cholesterol. And what we give to lower cholesterols are a drug called statin. Now, statins, they all end in statin, like atorvastatin. I don't know anymore besides atorvastatin, but they all end in statin, okay? So a good thing about this class of medications is that they all end in statin. So by recognizing that ending that I'm dealing with a cholesterol-lowering medication. So We also want to tell our patients that we want to give cholesterol-lowering medications at bedtime. This is because cholesterol-lowering medications work more efficiently because cholesterol is metabolized and produced at night. So when you're sleeping or as it hits the nighttime, you want to give this medication to your patient so that they can reduce those cholesterol levels. So that's a really good teaching point because a lot of patients take their medications all at the same time, but they should be taking those cholesterol medications at night because of the cholesterol being produced at that time. So that's a good teaching point, and it could definitely be on your exam, right? Watch out for that tobacco use because it can raise those cholesterol levels and build plaque.
Baby,
As
you're making me hot.
um, is somebody trying to say something? Sorry, I heard the mic go off for somebody. I just want to make sure nobody has questions. No? Okay, I'm going to continue. Okay, so continuing on, like I said, knowing about those risk factors also lets you know about what sorts of patient education I should be telling them, right? So no salty foods or just watching their salt intake because it's going to affect that contractility or the heart's ability to pump. And diabetes management, right? Because diabetes is a metabolic syndrome that can cause a lot of different things, but it can also cause plaque formation. So we want to watch out for that. And if we keep talking about hypertension and cholesterol and all of these things being either risk factors or patient education, then we know other manifestations would be watching their blood pressure, right? Or looking at their pulses and seeing their capillary refill, because that's going to tell us how well their organs and their tissues are being perfused, as that is an indicator is if our heart's working properly. Because if our heart's working properly, we should have normal capillary refill, which is less than 3 seconds. We should have pulses, right, at 2+. We shouldn't have anything that seems abnormal, right? We should have normal blood pressure. But sometimes they have comorbidities or other diseases, and some of these things might vary. But as a nurse, these are some of the things that you want to look at, right? Their cholesterol levels, because all of these can cause their manifestations. Is there any questions? No? Okay. So the next thing is we have angina pectoris or chest pain. And there's different types of chest pain. I've never really been tested on the different types, but it's good to know because of the fact that each cause different types of symptoms, and you'll know which type of angina you're dealing with, which means you'll know how to better respond as a nurse. So there's 3 types. And like I said before, chest pain is caused by ischemia or lack of blood flow. So that lack of blood flow is causing that chest pain. So that chest pain is the reason why the patients are here, but it's because of lack of perfusion. So something we might want to give them is nitroglycerin. Nitroglycerin is a cardiac medication that causes vasodilation or causes those vessels to open. When you open those vessels, that helps reduce the ischemia or that vasoconstriction and helps get blood to the area, which could help with chest pain. If it's stable chest pain or stable angina, that means it's relieved by common factors, right? So normally this person gets chest pain every time they exercise. That's an indicator that it's stable because it happens with the same triggering factor, and it is relieved always by rest, and they take a nitroglycerin tab. So something that I was tested on my cardiac quiz was how to administer nitroglycerin. This is very, very important. So like when you give nitroglycerin, you can give a maximum of 3 doses, and they have to be 5 minutes apart, and it's given sublingually or underneath the tongue. So they keep it underneath their tongue. They don't swallow it. They don't chew it. They let it dissolve. That is because you have blood vessels right underneath your tongue, and it's going to work systemically much more quickly. So you give them the nitroglycerin. They take their first dose. They wait 5 minutes. If the chest pain is not relieved, they take another one in 5 minutes. If after 2 of them, they still have chest pain, we want them to go to the hospital because it's not stable angina anymore. It might be unstable, and they might be having a heart attack. So That's something that you want to know. Also, with nitroglycerin, it needs to be stored in a dry and cool place. This is a really important teaching point to make, because if you're not properly taking care of your medications, the durability and the effectiveness are going to decrease. So this medication must be stored in a dry and cool place. The next thing is unstable. As I said, if the nitroglycerin does not relieve that chest pain after that second dose, we're taking them to the hospital. Unstable angina is a little different. So basically, unstable angina is not relieved by anything. It's not relieved by rest, and it's not relieved by nitroglycerin. And something that we may or may not see is ST elevation. And ST elevation is when you look at that EKG and there's the PQRST, that S and T interval is going to elevate or expand. It's going to look funny. And if that's it, they could have a heart attack. So we need to have immediate interventions, such as giving them oxygen, right? Because oxygen is going to help with that perfusion, which is causing this ischemia because of the fact that they're not getting enough blood flow. So that's what's causing this heart attack to occur. So we want to give them oxygen. We might want to still give them nitroglycerin to help with at least opening the vessels. Aspirin is always a drug that is given because it helps prevent future myocardial infarctions, and it's an antiplatelet. So it prevents clots from forming, which can also be a cause of a heart attack. If you have a clot that's blocking flow to your heart, that can also cause a heart attack. So we want to look at those things. And lastly, you have something called variant angina. And variant angina is, if you watched my cardiac lecture, if you didn't, it's okay. But I do recommend watching it with the drugs. Variant angina can be treated with calcium channel blockers like nifedipine. But these have, they might have a reversible ST segment, and they're not really sure why it's caused. It also may be caused to vasospasms. It's not really known as to why they get variant angina, but regardless, that means that they have a reversible ST. And that's really important because in unstable, it's not reversible. That means they're going into a heart attack. But if we can take the appropriate intervention, such as giving them oxygen, more vasodilators, we might be able to reverse that ST segment, and hopefully they won't have a heart attack. So those are the major differences between the three. And as I was kind of mentioning before, all these symptoms that you see in these cardiovascular diseases repeat. So they have tightness in the chest, a choking sensation, a heavy sensation, pain that radiates from the neck, the jaw to the shoulders. They have anxiety because of that lack of oxygenation. And because of that lack of oxygenation and perfusion to the heart, you have dyspnea and things like that. As I mentioned before, elderly might not have those same symptoms, so we just need to be careful, and you really have to watch them. Angina, as I already said, giving them oxygen, possibly vasodilators, morphine to help with the pain. And also morphine has it helps with actually the cardiac contractility, and it helps decrease the work of the heart. So even though morphine's a pain med, we can help with that. But if we give them morphine, we really have to be careful for respiratory depression, as that's an important side effect of all opioids. But we have medications. As I said, we already talked about nitroglycerin, where it must be treated, how to give it. Vasodilates, we need to decrease blood pressure, because anything that vasodilates decreases blood pressure and helps with that ischemia. And a really important side effect is a headache. You can get a headache from nitroglycerin. Beta blockers, because they work on the heart with those beta 1 receptors. And with those beta 1 receptors, that can help decrease the heart rate and decrease, the blood pressure, which can help with aiding in reducing that ischemia or that vasoconstriction that they're getting towards the heart. Calcium channel blockers are another form of medications that you can give. Any kind of antihypertensive can work in this situation, especially if blood pressure is a contributing factor. Antiplatelets, as I said, something like aspirin to prevent clots, prevent any sort of further ischemia. And I have no idea what a glycogen, I don't know what that is. So I'm not going to explain what that is. But always when someone has pain, the first thing we want to ask them is, when did it happen, right? Where is it and what does it feel like? Because if they said, oh, it's just pain in my chin, that might not be an indication. But if they're saying, oh, yeah, the pain's radiating and it's coming down my arm and I noticed it happened after X, Y, and Z and it's not relieved, then we might be talking about a heart attack. So we need to really understand. So it could be tricky, but if there's a question about a patient comes in with chest pain, you want to ask them about the chest pain first before you start sending them to the EKGs and getting like cath labs. We don't want to do anything crazy right away. We want to assess it because we don't know. If they said I hit my chest this morning and it's been hurting me all day, that might be a little different scenario. So we really need to understand where that pain's coming from so we can have appropriate interventions. Like I mentioned already, all of these goals is to prevent or decrease that ischemia and help with the perfusion. So we're going to do interventions that are going to help with that. And if we said we give them that nitroglycerin, they take it 5 minutes apart. So the first one underneath the tongue doesn't do anything. Second one underneath the tongue, nothing. They've really got to go to the hospital. Okay. And other things, like I said, controlling your diabetes, hypertension, and all that, because they can be contributing factors to having a myocardial infarction or chest pain. Not that I'm not saying those two are the same. I'm just saying whether you have chest pain or myocardial infarction, these risk factors are the same. And you're going to see over and over diabetes, hypertension, arteriosclerosis, hyperlipidemia. All of these are the risk factors. So all of the patient teaching becomes the same. Administering oxygen, as I mentioned before. These are all nursing interventions that I keep mentioning. But like I said, I will send you my notes after so you can read through them more and have more information if you need, but I'm trying to highlight everything as I go. Like I said, always talking about those diet changes, lifestyle changes to really help in reducing the risk for anything future. Okay, so another thing that we're going to talk about is MI. Everything starts to repeat if you're noticing. So I'm not going to get too crazy into the symptoms, but you see chest pain, elevation in the ST, right? As I said, it is a myocardial infarction is caused by ischemia. Acute coronary syndrome relates to that because it causes death or cell death to some of the cells in the wall of the heart muscle. And if in this situation, it's not irreversible yet. In the acute coronary syndrome, it's getting to an MI and it could lead to death. So if it gets to death, we're in an MI, and that means we have irreversible damage to the heart. So these two are sort of related, or you could kind of say interchangeable, but I've only seen them ever ask about an MI. They never really mentioned acute coronary syndrome, but acute coronary syndrome, as its emergent situation caused by this ischemia, will lead to an MI. So that's what I want to point out. It will lead to a myocardial infarction. So same thing, that chest pain, that hard of breathing, or that impending doom feeling, because if they're having lack of perfusion, that lack of perfusion is going everywhere, which means all their body is feeling this lack of oxygenation, which is making them feel anxious, right? Increased heart rate, increased respiratory rate, all of this stuff. So there's different things that are going on. And EKG change, we just talked about that ST elevation is indicative of a myocardial infarction. So as a nurse, or even on your test, if they say, here, what are some of the things you should look for in an MI, or what are some labs or changes I might see, you're going to see potentially an ST segment elevation. Very, very important is to knowing which cardiac enzymes to look at, because you must take labs. When someone has a myocardial infarction and they're having that chest pain and it's unrelieved, we want to get them to a cath lab within 90 minutes because we need to open that perfusion before it gets worse. In between, we're giving them the oxygen, we're giving the nitroglycerin, the morphine, the aspirin, but that's your nursing interventions, and always go with the ABCs, airway, breathing, circulation. So you want to give oxygen first, but we got to get them to the cath lab, and we want to look at troponin, creatinine, kinase, MB, and myoglobin. But troponin is the most important one. That one's elevated, they're in an MI. Not good. And once again, anything can cause an MI that's cardiac related. So heart failure, arrhythmias, cardiac arrest, pericardial effusion, which means that you have layers around your heart and the pericardial sac surrounds your heart and cushions it. And what's happening is effusion means that fluid is building. So they're having fluid build around their heart. And cardiac tamponade is also a fancy way of saying fluid buildup in the pericardial sac, and pericardial effusion will lead to a cardiac tamponade. But regardless, right, all of these things can lead to coronary artery syndrome or MI because it's all ischemic. The heart's not working properly. There's a lack of perfusion to the body. The same sorts of things are happening. So everything is, like I said, relieving that pain, getting that perfusion, reducing the anxiety. Everything is the same. So everything that you're seeing with your interventions relates to all the symptoms and everything that I've been saying. Different things can be as a stent or a cabbage or a PCT. There are different ways to open up the blood vessels to help dilate and get blood flow. All we're trying to do is get perfusion back to the heart because that's what's causing all of these things. As I said, coronary arteriosclerosis can lead to MI. Hypertension can lead to MI, arrhythmias, everything, because they're all related to this idea of ischemia or something blocking blood flow to the heart. Nursing management, if we have some sort of invasive cardiac intervention like cabbage, or we have a surgery where they're taking something and they're putting it into the body and they're trying to open those arteries, then we need to have some of that preoperative or nursing education on surgeries, right? So we want to provide education. We want to maintain cardiac output. We want to watch their electrolyte balance, especially if they're going to go into a surgery, right? Maintaining adequate tissue perfusion, maintaining normal body temperatures, because something that happens when you go into a surgery and you go under anesthesia is something called malignant hypothermia. And that means that they're having like an allergic reaction to the anesthesia, and essentially their temperature is going to go skyrocket high. That is why we need to watch out for their temperature while they're in the surgery. Okay, so I just finished that. Is there any questions on chapter 23? Once again, type in your SFC ID number into the chat if you haven't done so already. Okay. Doesn't seem like there's any questions. So I'm going to continue. So heart failure, again, another complication of having a cardiovascular disorder. Heart failure can be congenital, as we're going to talk about in our pathophysiology part, where it's some sort of structural abnormality. But it can also be caused by having hypertension and all these other things that we said before, hyperlipidemia. All of this can cause the heart to fail and not pump properly, so the ventricles are not getting blood out to the rest of the body, because we need our heart. It acts as a pump, and that is the most basic way of saying the pump of your heart failed. So, and as I said before, arteriosclerosis, because it causes plaque buildup, and the coronary arteries, which perfuse the heart, are having plaque buildup, which means not enough blood's getting there, which means the heart flow or the perfusion to the heart, not good. So they will also have decreased activity tolerance, right? If your heart is not really able to pump properly, you're not getting perfusion to the rest of the body, which means you're not being oxygenated. And if your bodies aren't, organs like your legs, your arms, your hands, whatever, your lungs are not being perfused properly, you're going to be more tired. But there's something really, really important about heart failure, and it's distinguishing what types. There can be congenital or congestive, that's the word, congestive heart failure, which means you could have left and right-sided. But you need to know what left-sided and right-sided. I promise you're going to have a question on this on your exam. I know they gave me a question where they listed the signs and symptoms and they said what type of heart failure it was. So you need to know which one's left, which one's right, because if the question shows symptoms of both right and left-sided, they have I just forgot the word that I said, but they have both-sided bilateral heart failure. So without further ado, left-sided heart failure I want you to think about the anatomy of the heart, right? So when your blood is getting into the superior inferior vena cava, you're going to have blood go into the right atrium, then into the right ventricle, and then it's going to go into that pulmonary trunk, and it's going to then go into the pulmonary arteries, which carries that deoxygenated blood to the lungs. The lungs are going to reperfuse that deoxygenated blood, give it some oxygen, and send it right back into the left atrium to go into the left ventricle, then shoot right into the aorta and send all that blood to the body. But in left-sided heart failure, that ventricle can't pump that blood to the aorta and can't really get it to the rest of the body. So instead, it kind of backtracks. So it doesn't leave the lungs very efficiently. So blood starts to fill up or pool in the lungs. So all of the symptoms that you're going to get for left-sided heart failure relate to pulmonary. So pulmonary congestion, crackles because of the fluid buildup, right? Because crackles are caused by fluids or something being present there, making that sort of crackly like sounds. A cough, they have dyspnea, orthopnea, which is a fancy way of saying they have trouble breathing when they go from a lying to a standing position. But think about it, right? If your heart's not able to pump and you're moving and you have decreased tolerance for anything, that gravity or the of pressure of just getting up and moving is going to be a lot on your heart. So it's really, really important where you're seeing these respiratory-like symptoms because of where it's building up. It's going back into the heart. It's going back into the lungs because we're already in the heart, my bad. But yeah, well, anything, pulmonary edema, right? The lungs start to swell, and a really thing in a late stage of left-sided heart failure, you'll get something called pink frothy sputum. That's a sign of pulmonary edema. That could be on your test. I know it was on my test. Oliguria. So the reason you get oliguria, so mainly if you can't remember much, know that left-sided causes respiratory. So any sort of respiratory symptoms that you see on a select all that apply or anything, go for them because that indicates left-sided. If the question asks about left-sided heart failure symptoms, go for all the respiratory ones. But think about it, right? If I'm going to not be able to perfuse to the body because the left ventricle can't pump it into the aorta to get it to the rest of your body, your kidneys aren't going to be perfused. And your kidneys hold about 25% of the blood that you get from the heart. So the kidneys need blood more than every other organ besides the brain in your body. So you're going to have oliguria or decreased urination or urination less than 30 ml because normal person pees 30 ml per hour. That's because of all of this. So oliguria is a symptom that you see in left-sided heart failure because of the idea of the aorta not being able to pump blood to the rest of the body, especially those kidneys. Decreased O2 stat, like I said, anything that has to do with respiratory, and an S3 heart sound you might hear in the elderly. Right-sided heart failure is a little different, right? That means that right ventricle can't pump to the lungs and it can't pump it to the left side and it can't get to the rest of the body. So it starts to back up in the body. So you get edema in the lower extremities. You get right jugular vein distension, which is a vein right under in your neck. You also have ascites, which is a fancy way of saying like fluid buildup in like the abdomen area or just fluid buildup. Weight gain, that's because of all the fluid backing up into the body. Anorexia, which this might seem weird, but it's the anorexia because they don't have that tolerance or that ability to really eat or do things. Splenomegaly and hepatomegaly. If you look into the anatomy of the body, when the blood backs up from the right ventricle into the body, the spleen and the liver are right there. So because they're right there, the fluid starts building up in those two organs as well and causing swelling. Megaly means swelling. So the liver, hepatomegaly, liver, splenomegaly, the spleen, they both swell. You also have fatigue. I wouldn't really worry about the CVP. That's more of a critical care thing, and I don't know much about it. But the best way to remember it is left LL, left backs up into the lungs. I expect to have lung problems with this patient. Right-sided heart failure goes back into the body. I'm going to have body or systemic symptoms. So once you know the systems, you're starting to figure out what becomes important, right? For my left-sided patient, oxygenation is going to be really, really important for them. And, making sure we're really watching that respiratory rate. For the right side, we're having weight and fluid build up and we're having weight gain and all of that stuff. So we really have to watch out for daily weights with these heart failure patients because daily weight is going to indicate if they're having any fluid buildup in the body. Also, left-sided heart failure can cause right-sided heart failure because if it continues to back up from the lungs, it's going to go right back where it came from, which is the right side. So that is why you always need to take daily weights with both of them. But these are just things to consider, right? Medical management has to do with the symptoms, right? O2, maybe surgical intervention if it's that bad. Lifestyle modifications, because as we said, there's a lot of things that can cause or lead to heart failure. And there are a bunch of different cardiovascular diseases and illnesses and whatnot. Medications, those diuretics. Why? If they got edema, we want to remove that fluid. That's also why we want to do daily weights. Daily weights is definitely going to be an answer somewhere. I don't care where it's going to be there. I know that. So if a patient has heart failure, you really want to watch out for daily weights. You can give beta blockers or ACE inhibitors because they also lower blood pressure, they lower the heart rate, and that can help with the body's ability to have perfusion because we want to decrease the work of the heart because the body's already trying. It can't really pump properly. So the heart's working even more than it has to try to get blood out because it's not working efficiently. And digoxin does that. Digoxin actually increases the heart's contractility without increasing the heart rate. So that's why we love digoxin for our heart failure patients. Other considerations, always your elderly population because they have decreased renal function, which means that your drugs that you take are always excreted usually by the kidneys. So if you're not going to have good kidney function, you might not have a easy ability to metabolize those drugs, and you might just get toxicity in the body with these medications. It's not good, especially with those left-sided heart failure patients. Why? Because the blood can't get to the rest of the body and it can't get to those kidneys. And if we're starting to see our patient has oliguria or a weak urine output, we really have to start seeing how their kidneys are doing. Like I said, we want to see how they're doing. We want to look at the signs and symptoms, right? Also, they might have a pulmonary embolism or something. So pulmonary embolism means they have a clot in the lungs. So we want to watch out for things like that too. Is the body's ability not to be able to pump blood to the rest of the body causing a clot formation? Are they having crackles or wheezing? Are they having mental status changes because now their perfusion is so low to the point where now their brain is being affected? So those are things that we want to watch out for. Once again, anything with heart failure, we want to improve their activity tolerance. We want to relieve the fluid overload somehow, which is usually by diuretics. We want to decrease their anxiety, manage those symptoms, elevate the head of the bed, especially for those left-sided heart failure patients because they have problems breathing. So elevating the head of the bed is going to help with that. All of these symptoms, like I said, you can read all of it on your own with the interventions, but think about the symptoms. All of these interventions start to make sense. Stress management, daily weights, INOs, fluid restrictions, sodium restrictions, especially because of the fact that it can further increase the work of the heart. Watching out for electrolytes, watching out for signs of pulmonary edema, right? Because pulmonary edema causes that pink frothy sputum that we see in the left-sided heart failure. So we really want to watch out for signs and symptoms of that, restlessness and cool, clammy skin and things like that. And always, because if anything has to do with pulmonary, we really want to give oxygen. And oxygen is going to be, if you have a priority question, pick oxygen. It's when in doubt, especially with these cardiovascular diseases, they're causing ischemia, oxygen is going to help promote perfusion. I would pick that. Like I said, with medications, You could definitely start looking into all of these. I definitely recommend watching the cardiac video if you haven't, but knowing them because they could easily ask you about signs of toxicity for these, especially they can give you a perfect scenario where it's like an elderly patient has renal failure and they also are now been diagnosed with heart failure and they're given digoxin. What are signs of digoxin toxicity that I should watch out for? And that includes the most important ones are nausea and vomiting, anorexia, and seeing something halos. If they see green or yellow flashing lights, no good. Interestingly, I have to change this. It's not hyper, it's hypo. Um, Hypokalemia can further, or low potassium levels can make digoxin toxicity more likely to occur. So we really want to watch our electrolytes, especially if they're taking diuretics with that. We got to be careful. And all I said, I'm not going to go too much into the medications because I have a whole cardiac YouTube video and we don't have that much more time and you could read into it. But it's fair game for your med-surg quiz to ask about these medications. But the main medications include digoxin, diuretics. Like I said, if we're taking the two of them together, digoxin and diuretics, we're watching those electrolyte levels. Autotoxicity, by the way, is a very bad adverse effect. If that happens with your diuretic patients, if they're taking them, they must hold that medication, right? And we're giving something that's going to lower the blood pressure. Diuretics, blood pressure medications like ACEs and metoprolol, they all lower blood pressure. So we always need to watch out for telling them to change position slowly, right? To be careful because they might get really dizzy really fast because of these medications lowering their blood pressure. It may lower it too much and they may get really dizzy. As I said with those ACE inhibitors earlier, angioedema or a dry persisting cough, they better stop that medication. These, like I said, all of these things are fair ball game on your exam. And with digoxin and beta blockers, you must take their heart rate for 1 full minute. You must take that. Well, for beta blockers like metoprolol, they end in that LOL ending. ACE inhibitors or any drug that ends in pril, like a enalapril, lisinopril, whatever. But if they're a beta blocker that ends in that LOL, we want to take their radial pulse. If they're taking digoxin, we want to monitor their apical pulse, which is their heart pulse, which is more accurate. And yeah, you said it's only on chapters 23 and 25, right? Am I correct with that? Or is
Yeah.
20? Okay, so I mean, management of hypertension, you'll see that. I don't know if that's going to be, do you know if peripheral vascular disease is on your exam?
I'm not sure. I don't think so, though.
Okay, well, I know it's in for patho, so I'm going to talk about that then. But for your NCLEX exam, you are going to need to know peripheral vascular disease. So I'm not going to teach you more than I need to, especially if it's not on the exam. But just quickly with the peripheral vascular versus peripheral venous, a really big distinguishing factor is peripheral arterial disease means it affects the arteries, right? So the arteries are the ones that go to the rest of the body. So we expect things like pulselessness and pallor and necrosis or the tissue's dying because they're not getting perfused. Hair loss on the toes and legs must always be down because that's going to promote the arterial blood flow. Veins are the opposite. Veins go from the body to the heart. So we want to elevate our legs because that means the veins aren't working properly. So we want to elevate our legs. They're going to have warm skin because the arteries aren't affected. The arteries cause that warmth to our skin, but it's not the arteries that are being affected, it's the veins. So we're going to have warmth because circulation's not cut off. We're going to have pulses because arteries aren't being damaged in any way in peripheral venous disease. I just wanted to put those things out, and legs must always be elevated. I just wanted to mention that for someone who might have it, but I know you all have Remy, so if that's if 27's not on there, then don't worry about it. Um, but yeah, I'm going to stop recording.